Okay, so let's get started. Hello, and thank you everyone for joining us today. Today, it's the first of a series of quarterly webinars that we are going to organize to be focused on the use of DHIS2 for immunization programs that have been developed together with the WHO, Gavi, and UNICEF. In these webinars, we are trying to bring forward some real-world use cases and to share a little bit experiences of implementations and best practices among end users, so a bit everyone here, and also stakeholders. The first webinar, so today, is going to be about innovations and challenges of implementation, especially of COVID-19 related immunization implementation toolkits. And today, the real protagonists are going to be the HISP network and the work on developing and implementing these tools for data collection, analysis, and reporting. So just to get a little bit an overview of the DHIS2 Immunization Toolkit, what we have been developing together, again, WHO, Gavi, UNICEF, just to mention a few, it's a wide range of toolkits that can be used either to measure coverage, distribution of vaccines, so the EPI module for routine vaccinations, as much as, for example, for mass campaigns or in general emergency campaigns, such as, for example, the COVID-19 that we are approaching now. And we are spanning also now to ensure that individuals, for example, are monitored throughout their doses, so immunization registries for individual data, as much as the management and the overview of supply chain readiness. So we have both aggregated and individual data for supply management. And as you will see also, we also have the possibility to link also to have vaccination record or certificates. In general, overall, we have a wide range of vaccination toolkits, and they're all there to help us out to inform strategy adjustments, to have quick, a real-time overview, uptake, data on uptake and coverage, and as much as to have, for example, data for trends in geographic spread and just general visualization, and to have also a good standards of data, so we can have apps such, for example, the bottleneck analysis or the vaccination app, or as well, for example, the data quality app. Overall, just to give you an overview of the spread or the use of DHIS2, 45 countries use DHIS2 for immunization data, and already 30 countries have already installed the WHO Epi Package. Specifically for the COVID vaccine toolkit, we have here the general overview. We have already 25 countries that are operational and running their activities based on DHIS2, and 8 are in development, and there are more to come. So without further ado, I think that we can move forward with the real essence of this first webinar. And today we're going to have 3 HISP groups that are going to present us their experiences of implementations with different success, key elements for success, but also challenges and ways that they have overcome these barriers. So the first one is going to be HISP Mozambique, so DHIS2, with an example of real-time analytics and data cleaning for Sao Tome, and the pre-registration experience that they had for Mozambique. And then afterwards, we're going to switch to HISP Uganda, and where they're going to show us their work for approaches of real-time monitoring, and also the hybrid implementation between aggregate and individual data for Uganda and Mauritius. And finally, Sri Lanka with their work for the scale-up immunization registry for Sri Lanka and Timor-Leste. So I leave the stage to HISP Mozambique and therefore Zeferino.
Good morning, everyone, or good afternoon, I think. So I'm Zeferino Saujan. I'm leading the team, called South Digital or HISP Mozambique. So as it was mentioned previously, we have been supporting the Lusophone community with the implementation of the COVID vaccine packages. And there's also now the experience that we are going to share is mainly related to the work that we did in Sao Tome and Mozambique. So for Sao Tome, the package was after getting from the University of Oslo, we did adjustments of the package and presented to the country in order and then make the adjustments of those to make sure that they align to the national guidelines and also the plan, the COVID vaccine plan that was developed for the country. And then so basically as part of this process we did some activities, and then there were some success process or activities which were mainly linked to the aiming to improve the planning for the vaccination teams, and they also developed some real-time monitoring dashboards that aimed at help the team that were managing the vaccination process, the API, basically the API program, the HMIS, and the surveillance teams, in order to have the view of what is happening, what was happening in each vaccination site. There were also allocated in each of vaccination site supervisors, both to monitor the vaccination process, and there were the HMIS allocated also focal points that were monitoring, or they are monitoring the data entry, the data entry process. So this has helped to get the data somehow on time that could be used to do the monitoring of all the process. So with regard to the training, we did provide some face-to-face trainings, and then also visited most of the sites, 9 plus sites that aimed at helping the users on the issues that they were facing. So for Sao Tome, this was the first tracker, let's say, implementation, national-wide track implementation. The country was using DHIS2, but the focus was on aggregate. And even though we did start the customization of the tracker from the beginning of the year, but there was not yet it was not yet rolled out nationwide. So there were some challenges, which, for example, the training that we did here, it was 2 days before the start of the vaccine process. So those was that also brought some challenges that needed us to visit the sites to fix. And also there were some devices, Android devices, that were prepared to be used for the vaccination process. But when we came to the training, we found that it was not a good approach, because the users were it was the first time for them to use the Android app. So we did decide not to use that. But for the second dose, so there were training. So some of the users, they might be, or they are using those devices to enter data. And then also we did create some WhatsApp groups with the data entry clerks to share the experience, and also there were other groups that were used to share the experience with the supervisors, so that they could use that to then share all the problems that we are facing, and then what the approach that could be used. With regard to the visits, there was a first visit, and then there's a second visit the first visit was meant to provide the first training and then do the follow-up. The second visit, it was targeting to try to because there were some issues that we had to go through after the vaccination, which was data cleaning. There were some duplication of the data, And then those things happened in between the two doses. So we had to go there for the second, before the second round, to make sure that we train the users, and then they went and give them the tricks that how they could deal with the several issues, both for the HMIS that they are administrating the process, as well as the users. With the barriers, I mentioned some, which are the trainings and also the planning process, and also there's a pressure to have the data to be entered and then sent on time. It was one of the barriers. And then one of the ways that we did it was to have the double, both the aggregate and individual level, to be sent, the data to be entered in DHIS2, the hybrid process, so that the data could be, or at least the managers at the national level, they could have the clear picture what the total number of people that we have vaccinated. Next, please. Well, so going back to Mozambique, the approach was similar. In Mozambique, the experience now is related to the above how we also as part of the process before even the vaccination. For the first round, in the planning, in the process, the country was targeting to vaccinate health workers. Because of that, we requested to have pre-registration. We have the list of all entered before in DHIS2, so that they could speed up the whole process. But of course, this list was not provided in full, and there were some information that was only received during the vaccination process, that also did not make for example, the users to benefit from having this pre-registration approach within DHIS2. At the moment, we are working on this for the next groups of people that are going to vaccinate it. We know that at the moment there's also a project that private company, they are gathering themselves they will be bringing some vaccines to the country, and those they will be using the system to provide those vaccines. So we are preparing this pre-registration to be of benefit, at least to all that are going to be used, and then based on the experience that we had previously, to make sure that we won't face the same challenges. For Mozambique, it was also a hybrid implementation, tracker and aggregator. Even for now, for the second dose, we are still using the same approach, because the country is huge. There were some challenges, for example, related to the internet in the beginning, so that it was difficult for them to be able to send all the individual levels as compared, for example, to Sao Tome, where it was easier to have that. So that's why until today, the approach is hybrid. They send the individual level data. At the end of the day, also they send aggregate, so that they know what is the target of the day. And the WhatsApp groups were also used to, especially to share, especially in the first days, we did have everyday meetings with the supervisors that were shipped to the provinces. And those that were their responsibility it was to deal with the users, and also the focal point in the districts. So at the end of the day, we had to sit with them and then find all the problems, try to address the problems, align all the strategies that were used. For example, the approach that were used in one province, which was different from other provinces, so we could share and then make sure that the process was flowing smoothly, as well as the pre-registration also. Difficult, so approach that we're using one province could be shared, and then also with other provinces. We did as also training. The training were mainly virtual training, which also brought some barriers because of the COVID, and then that was the reason why, for example, we decided to have the hybrid, to use the hybrid approach. And the planning, there were some internet and device issues that were not very well organized in the beginning, but with the process, the country started putting what was required to make sure that the process is flowing smoothly. And then I also mentioned about the number of people that were not, or the list that was not received one that also was a barrier for the use of this pre-registration, or for the benefit of the pre-registration. So these approaches are also used in other countries, like in Cape Verde, where they were doing the interoperability. And yes, that's what I have to share at the moment. Thank you very much.
Thank you very much, Farina. I think we can pass to Uganda. So, Dr. Prosper, I'll leave the floor to you.
Yeah, thank you very much. And good morning, good evening to all our participants for today's webinar. Yeah, what is very interesting is that, I mean, with the DHIS2 approach and implementation, it's all the same. So pretty much of what is Farina presented is the approach that we try to follow across the different implementation. But particularly for Uganda, it was at the point where we had started from paper tools development. So we provided TA to the team, to the UNEPI team at the Ministry of Health to develop registers, vaccination cards, reporting tools. We were able to install the package and customize it to the requirements of the Ministry of Health in terms of COVID vaccine management. We participated in all the trainings online. Most of them have been online, and we've been consistently supporting trainings. We're having ongoing trainings, and we're also supporting the end users. We've used the approach of a district to take advantage of the knowledge and the skills within the district for the general DHIS to support training and roll out the lower TOT. So we train the districts, and then the districts in turn train the lower levels. But it happens that, you know, being online, wherever even the health facilities are able to join into the weekly trainings that we have, even facilities, including the partners who are supporting these districts and facilities at lower levels, join into our trainings. And it's a training, question and answer, and the teams sharing their challenges, and we'll step by step able to take them through the demos, some follow-up with phone calls, WhatsApp messages, and all that is the approach we use for the training. We've had quite a lot of support because the funding was not really available for the vaccine campaign. We've had a lot of partners coming in to support this initiative. We've had CDC support with laptops for all the districts, 152 of them that we dispatched this Monday. We've had the NORAD supporting data bundles for some of the districts. We had UNICEF with some tablets in some districts, USAID and WHO with tools, and also some partners have supported with HR at facility level to do data capture and reporting. We have one solution so far. I'm saying so far just because what we've seen, especially in the COVID vaccine, in the COVID surveillance, instead of partners and coming to support what is already existing, we've had to see partners introduce some parallel systems which have parallelized some of the systems. So at the moment, we're still using DHIS2, the COVAX track package as our immunization registry. As I shared again, we are using weekly meetings, half a day, and whoever is able to log in, it's a public coming, and then we are able to train them, and then specifically address some of the challenges that teams are facing. In terms of the challenges, and like any other country, any developing country, this was not planned for. So we have limited funding from the government to support all this hardware, human resource, and the requirements for a registry. Dedicated staff for data capture. We are now vaccinating in over 1,500 vaccination points. So that would require over over 1,500 data input clerks to be able to use the devices if they were available on site. We have limited devices. As I said, CDC just gave 152, but that's at the district level, and each district has at minimum 5 vaccination points, so you can imagine. We're also having a challenge of using both paper and the electronic. So again, this of course introduces a lot of backlog, but most importantly, the handwriting challenges that has to be transcribed from the registers to the electronic system, let alone. And because of the funds and the challenges of travels, we have done all our training remotely and limited support supervision. So you do find that some of the districts who have connectivity challenges are not meeting regularly. So with this delayed update of e-registry, to be able to inform planning, we had to devise, next slide, we had to devise means of how we can be able to quickly get data from the vaccination center for planning. So at every end of the day, at each vaccination point, they're supposed to submit their daily report. And this is basically looking at the key elements, just 6 of them, to really inform the next meeting for the security reporting and also for the planning of the distribution of vaccines and also checking the progress. So we have both SMS reporting that coded going through the government prepaid SMS shortcode that all the health workers can be able to submit this data at the end of the day. They could also be able to use the web to enter this report, and they could also be able to use the DHIS2 Android to enter the report. So that's the format, very simple, but very key elements that we need to get and monitor the reporting rate on a daily basis. Next. So again, we also do through our HISP networks and support to other countries. During one of our webinars, when we're introducing the COVID vaccine package, DHIS2 package, the Mauritius picked interest and they were on their own trying to install, because Mauritius has always been using DHIS2 as their HMIS team. They are just they're just starting right now this year. And all this has been happening during the lockdown. So Mauritius picked interest, and because the HMIS team at the ministry has been participating in several DHIS2 trainings, academies, so they were able to quickly set up and we supported them to install the package to be able to support the COVID vaccine registry. Of course, it's a small country with a few facilities. It's been very easy for them, and they set up from the start with support from partners, WHO. They were able to set up, to allocate human resource for electronic data entry, and so the staff were trained. So for them, they have really implemented a fully fledged electronic COVID registry. Later on, they were able to introduce the online registry, pre-registry and booking system, which we supported them to be able to integrate directly to the DHIS2 tracker, so that when the people come to the vaccination center, they are able to be retrieved and only enter the data for the vaccination. Of course, the barriers they have had is because of the travel restrictions, we have had to do all this online. They have had to bear some sleepless nights to catch time from Uganda to be able to go over some issues and implementation. They were very, very keen team that they really wanted to run on job. So that's why we had to hold some, late evening sessions to be able to take them step by step and support the customization and implementation. Of course, the challenges with the IT personnel at the national level, being fact that they had not used DHIS2 for implementation, they had a lot of issues around server management, which we've been able to remotely support on. Mauritius has been a good example of where you start from no DHIS2 and you quickly jump on this e-registry, and within no time you have real-time data on an individual level basis. So that are some of the few things that we can share with you, but it's been a lot to learn from these 2 implementations. Over to you.
Thank you very much, Prosper. Super interesting. So next one, we're gonna get started with Sri Lanka. So I leave the microphone to Pramod.
Thank you very much. So good morning, good afternoon, good evening, everyone. I'll be briefly talking about what we have done with COVID vaccination and DHIS2 in Sri Lanka. Just like the use of COVID-19 for general COVID, use of DHIS2 for general COVID-19 surveillance, Sri Lanka was the first country that we implemented the immunization modules on DHIS2. And the package that we installed on DHIS2, it had all these components, which is the immunization tracker, where we are tracking the individual persons across their immunization schedule. And of course, we had aggregate component for stock monitoring. We also had to do some custom development to enable the digital vaccination certificate. And we also have integration with the government vaccination appointment system, so that we get the information pushed from that system to our existing DHIS2 based immunization module. Next slide, please. Right, so like since we started off this very early, it was in November last year, we had a lot of challenges. The initial challenge that we had was like we needed to have some guidance on how to design this tracker or rather the immunization module on DHIS2, because at that time this was a whole new concept. So we had to obtain some assistance from some experts locally as well as internationally for that one. And then again, another major challenge that we had was one requirement of from the Ministry of Health was to pre-register the entire population, rather the entire adult population of Sri Lanka. So we are talking about enrolling 16 million track entity instances to the vaccination program in DHIS2. So it was considered a major challenge how to get this information. We of course got it from the Elections Commission, who had it in a kind of a CSV file, and then how to push this 16 million entities into the DHIS2 was a major challenge. And then because we are talking about 16 million, it was of course a large scale tracker implementation. So when your instance become very large, everything about managing that instance become really complicated, like from, for example, starting and time taken to run the analytics. And in case if you do some mistake, how to correct it. So all these things become much complicated when you have such a large scale tracker. So we had a lot of challenges with that. And then of course, with the large scale tracker and the way we set up our instance was like we set up analytics and dashboards available for all the levels. So with that one major requirements from the Ministry of Health was to have analytics, real-time analytics enabled. So in addition to capturing data, we had to serve this requirement of giving analytics based on dashboards. So this was again kind of pushed the platform beyond its limits. So there were like some challenges related to the platform performance as well. And then with the WHO Smart Vaccination Certificate Release Candidate first release candidate guidelines, the ministry was keen on having a digitally verifiable, in fact, a cryptographically verifiable digital vaccination certificate. So we had some challenges related to that as well. So the success, of course, we were able to set up this instance, which had the tracker and the aggregate both. At the time, we received the first batch of vaccines. So in fact, like we were ready with the system when the vaccines came. So the very next day when the country was ready to start the vaccination program, we were ready with the system. And then the pre-registration of the entire population. So it was a major task. We had not tackled an instance with 16 million before. So this is where we got support from the DHIS2 community and the DHIS2 experts in at the UIO level and the HISP community. So we had a couple of discussions with all of them to decide on the best way forward. So with help of many, we were able to successfully import all these people, the persons, adult population into the DHIS2 system. So which was a major success for us because we were able to do it in a short span of time. And of course, optimum use of tracker, aggregate and custom development. So we kind of leveraged on capacity that we had and the experience from our past implementation on COVID surveillance to see that we have to have a combination of all three methods to get a successful implementation. So similarly, even for the COVID vaccination, we got our tracker, aggregate, and in addition, whenever something is not possible, we went custom solutions on DHIS2. And of course, we had the smart vaccination certificate, which was done based on WHO recommendations. And for this one, of course, we again used few other open source solutions that were there to produce this vaccination certificate. So we made use of available resources than trying to reinvent the wheel. And we did an integration so that we just push the relevant information and get this certificate generated. And then again, conducting training programs was a major challenge. But of course, we used this single page user documents and the Zoom platform to conduct trainings at different levels. So we initially trained the district level. They again use Zoom, mainly Zoom, to conduct their end user trainings. And we also use a Viber platform, an instant messaging platform for troubleshooting, as well as remote desktop solutions to connect to the users remotely whenever we find it difficult to troubleshoot. So multi-sector engagement was again a major success in Sri Lanka. So we, not only the HISP Sri Lanka, we work very closely with the Ministry of Health administrators and the health informaticians. And in addition, we obtained the support of the government ICT agency who looks after our infrastructure, as well as they are the people who are supporting with the integration with this DIVOC platform. So these are a few of the factors which contributed to our success in Sri Lanka. And next slide, please. So next we will briefly talk about Timor-Leste, and my colleague who is based in Timor, Achala, will proceed with. Over to you, Achala.
Thank you, Farina. Good morning, good afternoon, and good evening, everyone. I'm Achala Jayathil from Timor-Leste. Let me start with a bit of history of DHIS2 in Timor-Leste. It's a new country. Back in 2013, the Ministry of Health decided to use DHIS2 as the platform for national HMIS called Timor-Leste Health Information System, abbreviated as TLHIS. In 2017, TLHIS was implemented countrywide to collect aggregated data in Timor-Leste. Given the existing poor infrastructure, there were no plans to implement a tracker this soon. Until last December, COVID-19 was not a big issue in Timor-Leste. But with the surge of cases around Christmas last year, everyone was interested in vaccine. In January, we learned that we are going to get about 130,000 doses of vaccine under COVAX towards the end of February. Then came the question, how are you going to manage vaccine information? In January, we were listening to a presentation from Sri Lanka on COVID vaccine tracker based on DHIS2. After listening to that presentation, after several discussions, it was decided to customize a tracker to capture vaccine information in Timor-Leste. That was in mid-January. We had only less than 2 months to customize the tracker and train the users. As you may know, Timor-Leste is a very new country with very limited resources. I'm single-handedly providing technical assistance to the Ministry of Health in DHIS2. However, with the help of WHO Country Office and HISP Sri Lanka, we managed to complete the customization of new DHIS2 instance for the tracker and user training by end of February. Meantime, vaccine arrival was postponed to 5th April, and it was decided to launch the tracker along with the vaccine launch on the 7th April, World Health Day. Next slide, please. On 7th April, tracker was officially launched by His Excellency the Prime Minister and His Excellency the President of Timor-Leste. Next slide, please. So these are some screenshots. Maybe we can skip that. Next slide, please. So let me discuss some success and some challenges we had to face in this project. Let me start with success. We managed to get a buy-in from Ministry of Health and nationally roll out the system after training of entire HMIS staff. Target population was enumerated and pre-registered in the system. And currently we are planning to issue a smart vaccination certificate for those who are completing the second dose from June. In Timor-Leste, we use aggregated data capture forms as a backup system. And we use event capture for supervision and monitoring of the vaccination campaign. So let me move on to the challenges. So lack of internet and frequent electricity failures are the main challenges we had to face. In some remote areas, no internet. In some areas, no electricity for days. So how are we going to enter data? That was the main challenge. So we had some similar experience back in 2018. We used SMS, like some of our colleagues explained before us from Uganda. So now this time we used WhatsApp platform to share images from the remote. They send the images of lists to the center, and centrally we enter data. And from the system administration point of view, number of organization units kept increasing. We have to add vaccination post to the system on almost daily basis. That is time consuming and challenging. Another challenge we had to face was COVID lockdowns during the training, as online training is not an option in Timor-Leste. So I had to undergo several PCR tests while traveling to the districts, and that is not so exciting. With the successful implementation of the tracker for COVID-19 vaccine, Timor-Leste is currently planning to expand it to the routine immunization as well. I think that is all I have for today. Thank you.
Thank you very much to both. It was really, really interesting. And finally, we have a quick overview of the country implementation support. And for these, I leave the stage to Rebecca.
Hi, good afternoon, good morning, everyone, depending on where you are. And thank you to our presenters for really sharing with us such a great range of both the successes and the challenges. So I think we have done a couple webinars to the public already, focusing on the global public goods. So of course, today we really wanted to focus on these implementation lessons and learning that can be applied by others, or they're scaling up their DHIS2 based immunization systems. So we'll be able to share some of these resources that are all available on our website that's linked through the community of practice. But we do want to point everyone to several pieces of guidance around the implementation guide in general, tracker implementation if a country is doing for the first time, individual level data capture, or also using the Android, DHIS2 Android app for their implementation. We also made available some COVID-19 specific vaccine budgeting guidance to give countries a starting point, including an Excel sheet to sort of think through which modules they would be adopting and be able to adapt some of these units and unit costs for their own environment, and really understand, what is the budget that's going to be needed to facilitate, particularly the country operational costs on this rollout. We produced some end user training templates. I believe it was Achala and Pamad who pointed to some of these resources where we've developed these end user training templates that can be easily downloaded and then adapted, so that you can leave your trainers with a resource or job aids, and just trying to make sure we're avoiding reinventing the wheel while we try to scale up these systems at unprecedented speed. And lastly, I did want to mention, we are very grateful to our long-term donors, and to Gavi, who has invested quite a bit in the global toolkit, as well as through a TCA grant mechanism, and as well as to NORAD, who have given us some catalytic funding to mobilize not only the global goods, but to be able to provide some TA to countries. So we did just want to emphasize that Gavi countries, if you are interested and you're on the call, you can reach out to your HISP focal point and your Gavi SCM to explore those opportunities for mobilizing TA funding and to be able to strengthen the immunization system. So I think it's all of our goals that this COVID-19 momentum will transform into actually really strengthening the integrated EPI, or national immunization system, overall. And lastly, I will leave you with some of these resources, as well as some contact information in case you are coming from a ministry or a country you don't know who your local HISP group might be. Do feel free to email us at covid@dhis2.org, and we'll help to identify the regional HISP groups that are closest to provide that support. So with that, I thank you very much, and I think we can move to some Q&A, if that's all right. And I know we have a few that are in the chat. So perhaps we can start with the first one from Hussein. So can offline Android application Will it work when there is no internet or SIM card? And Pamad, you already started to answer that one. I'm not sure if we have any representatives with Android as part of their implementation on the call from our HISP groups who might want to respond to the use of the Android app as part of the DHIS2 implementation.
Yeah, I think I can share this. Yeah, so what we do find out with the Android app, it's basically most of the time offline. So it will just only require you to have connectivity to, before you leave, you leave to the remote area. That is for you to be able to log in and the data gets synchronized to your device. So you can go offline with no connectivity. No need for GSM network and no even a SIM card. We are using tablets which have no SIM cards in some of our implementations. So when you come back, then you can use the Wi-Fi to be able to upload the data. Yeah, it does support that. Over.
Thank you, Prosper. And I actually think maybe this next one from Matt might also be a good one for you, Prosper. So some of these deployments where there are already an EPI registry, he's mentioning Uganda, where they also have deployed open SRP for immunization. What are the long-term plans for harmonizing the data or duplication in training? So I think harmonizing the data and also harmonizing training activities.
Yeah, thank you very much, Matt, for sharing that. Yeah, so what has happened in most of these pandemics is establishing some kind of parallel registries. Yeah, particularly for Uganda, the COVID vaccination has been established as a DHIS2 standalone instance, but using basically the Uganda HMIS metadata, that in terms of organization units and all that. So what has happened with most of the other immunization registries is they've been focusing for the children and underage. So they couldn't quickly come into support with what is registered there when it came to COVID vaccination, because we're looking at over 18 and probably the priority clients. But the long-term goal is to be able to have these harmonized. And particularly for Uganda, we are now in the process of developing what we call the patient or client registry. So whatever data will be picked, and already we have in the COVID vaccination and we have in this open SRP would be shared record that will be accessed through the central client registry. So the harmonization is going to happen. This was done for the sake of the emergency, but once we settle down, this all will be harmonized. The trainings, of course, yes, we've looked at the platforms that have been used for COVID training, and we also looked at what has been existing in terms of immunization support. This can easily be able to be harmonized as we move forward. So there are always a lot of synergies for us to be able to harmonize this and be able to move forward. Over.
Thank you so much, Prosper. And I think I can add to that a bit, Matt, perhaps from a more global perspective. For many of the countries that have been deploying these DHIS2 toolkits, many of them have, most of them, probably almost all, have established DHIS2 as sort of the backbone of their HIS architecture. So really being able to have those strong governance mechanisms in the country, and being able to have these different types of mobile apps and tools like OpenSRP to be able to harmonize that data collection and follow a data flow that gets into the national system, we believe would be pretty important. The second question was around the WHO EPI module with support for product tracking and supply chain capabilities. Curious about deployments where there are existing digital LMIS solutions that must also be interoperated with So this is a really excellent question, and maybe Victoria can have a word around how the core aggregate packages and incorporate some of this reporting of the facility level, this sort of last mile point of logistics delivery and data capture. So could be also considered the first data mile for that logistics data from the facility, because what we've learned from various global assessments on LMIS systems in country is that many of them, if there is an electronic LMIS that's functional and works across programs, it's not maybe just used for one or two vertical disease programs. Many times it does not reach below perhaps the district warehouse. But many countries are filling that gap by being able to capture the site level logistics data and then be able to exchange that between the LMIS, the electronic LMIS. And one of the ways that DHIS2 is able to contribute to that is that it has a reasonably quite robust analytics platform that sometimes logistics platforms don't necessarily have. For example, OpenLMIS. So many of countries have found it useful to also get some of that logistics data from the LMIS system into their national system and be able to triangulate that data with their vaccination service delivery. I believe PAMAD actually has a quite great example from Sri Lanka around having these sort of data triangulation dashboards with the stock data. So I don't know if PAMAD or Vito would like to add to this response.
From my side, just to add, as you said, the strongest point, even for something as considered as basic as an aggregated data set, is the fact that you can have a quick overview of the supply chain and the management of your pharma store, let's say, directly from the point of care. So you can have like a quick overview of your status of how many items are coming in, out, stock out days and such, both from as you also mentioned, like a stronger analytic ability that DHIS has, as well as like a geographic visualization that you can have also from a higher level in case of need, because you can monitor your information both at health site as much as a higher like a hierarchical level. And yeah, so far it has been used, integrated in the data collection procedures, integrated very well also in the flow of information, especially in those countries where the information flow is much more established because of like the HMIS side of things. But it's very simple yet incredibly intuitive and working very well for the point of care, and the incredible added value of having in one single platform the ability to triangulate data on the use and consumption of your goods, of your items, and see what kind of impact it has on your activities, on your medical activities or health-related activities. It's been a challenge, but it's been super interesting and super useful to see being uptaken. So I think for more like a use case, I think Pramod can definitely add something more to that.
Yeah, thanks, Victoria. So when it comes to how we use DHIS2 for stocks, is like we have a separate stock monitoring component, which is aggregate module. So what we do is now when we get the stocks at national level and when the stocks are distributed at each of the levels, we get aggregate counts. I mean, it's like a daily count. We have asked everyone to update. So we are using like, I mean, it's not just a simple aggregate data entry form that we are using. We are using also predictors as well to take the stock forward, and things like that. And based on that, we are getting updates from the vaccination centers and at the regional level, and as at national level, the vaccination stock information, we use that to update our vaccination dashboards. But I must say that this is not kind of replacing right now the stock management system which the Ministry of Health has. So that's a separate system that we use to track the other supplies, the medical supplies as well. But In the same way we set up for all other activities around COVID-19, this DHIS2 has been the kind of the pioneer in the solution that we were able to get it up and running to provide the useful information for us to monitor our vaccination campaign. But how we are going to have an integration, or how we are going to combine these different workflows into our generic HMIS workflow is something that we are really eagerly looking at in next few months to come. But at the moment, we are using stock monitoring, which is feeding aggregate data into our dashboards. Over.
Thank you very much, Pamad. While I have you, there was one more question for Sri Lanka that I would like to pull up. Is the DHIS2 vaccine COVID-19 data instance linked with other DHIS2 instances, or is it standalone? And what might be the plans for linking the different systems or instances in the country?
Right, again, a very good question. So as I mentioned before, we have one DHIS2 instance incorporating all the COVID-19 related information. Like we have one for contact tracing, we have one for laboratories, quarantine, ICU beds. So all these are in one particular main DHIS2 instance for COVID-19. But because we were anticipating a lot of challenges with the COVID immunization tracker, because it was going to be a large scale tracker implementation, we set it up separately. But what we actually do is we take the aggregate data, like the summary data from this instance, and we feed it into our central DHIS2 instance. Similarly, there are like some other third-party applications, for example, laboratory level data collection, which are being used by the Ministry of Health. We have plugged them also to feed data into our central surveillance system, so that we are getting aggregate data, which we can use to produce dashboards. So same thing we are doing for vaccination system as well. We have a separate instance, but it is feeding data periodically to our central COVID-19 DHIS2 instance. Over.
Thank you, Pamad. Let's see, we have a little bit of a tricky question. Any insights around LMACs that might already have a DHIS2 system installed and operational? So they're using DHIS2 in the country, but perhaps haven't shown a willingness to install the COVID-19 dashboard modules. And so what are the challenges there? I think there could be many, but I don't know if any of our HISP groups wanted to speak a little bit, or to the opposite side, why maybe we believe that these modules should be considered if the country is using DHIS2 as their national immunization platform in terms of sustainability. I don't know if anyone had any comment on. I think maybe the answer is it would be quite difficult for us to speculate, but I do think we believe that there are some efficiencies to be gained by really aiming to integrate some of these modules with the existing national immunization system. And partly, there are a couple notes in the chat here around how does this relate to the overall EPI system? And I think this is a really important question that I might also ask Vito, or maybe if Zephyrino is also on the line to input a bit. As these COVID-19 modules, it's really just another type of vaccine. And so there are some things that we have designed and accounted for example, capturing that data by the specific brand of the vaccine, recognizing that many countries are really aiming to monitor this coverage and rollout as close to real time as possible. So having either individual level real time or at least some sort of daily data sets to make sure that data is coming in faster. But I didn't know if Zephyrino or Vito wanted to comment on some of the linkages with the routine EPI modules and also within that health information architecture within the country, and what are the benefits for the countries to be able to integrate COVID into what they already have.
Well, from my side, I would say that, of course, right now, COVID-19 is an international emergency and has much more visibility. So it required something that could stand out and have quick access, especially for those countries that didn't have necessarily an integrated API module from DHIS, especially. So they needed something to monitor either surveillance for the case itself, but of course, here we're talking about immunization. If countries have both the routine immunization program and package installed in their system, having the added value of having COVID-19 vaccination system, it's in the end, it's just a fork of the same family, let's say. It's just that at the moment it has this particular need of being on its own, also because it's something new. We don't know in the long run how it's going to become. It could be that in the long run it's going to become just simple part of the EPI family because it's going to become a routine vaccination itself. But for the moment, it would be just a simple triangulation or simply an addition of those indicators that are normally used for the EPI, and simply adding as well those that are currently used in the dashboards or that are anyway in the system for COVID-19. So having both is it can be integrated very easily in a single dashboard if needed, because they're part of the same system and they are part of the same family in the end. Because yes, it was more of a let's call it mass campaign, but we don't know how we're going to go forward from that. And yeah, I mean, I don't know if Zeffirino wants to add anything to that, but I would say, yeah, I mean, it's pretty straightforward how to integrate it. It's just like considering almost a triangulation of different packages that are installed in the same instance.
So I wanted to thank you all for bringing your great questions into the chat here. We will try to update the posting on the community of practice to try to summarize some of these answers. And I think it's it's just very clear that we still have so much to learn from real implementation challenges and experiences. And so we were very grateful to have Achal and Pamad and Zeffirino and Prosper here today to actually share with us some of those country implementation stories that I think we will continue to learn a lot in the months to come. So I think at this point we have answered most of the questions that came through live. And so Max, I think from here we can close the webinar, and we look forward to continuing the engagement on the community of practice. And please do not hesitate to reach out to us or contact us if you also have a country implementation that you would like to connect with us to organize how you might have some support. So with that, thank you very much. And I think we can call this a close. Thank you.